Hello everyone and welcome back to my channel. So we have started the preparation for obstetric subject, and in the last previous video we have discussed the amniotic fluid abnormalities, that is polyhydramnios and oligohydramnios. In this section we are going to discuss the antepartum hemorrhage and postpartum hemorrhage. Okay, so for antepartum hemorrhage, this is very important topic in the field of obs and gynae. We are having a scenario that there is a G4 uh, that there is a G4 and P3 34 weeks pregnant with abruptio placenta brought to the labor room in emergency. So what is the management and what is abruptio placenta? Another scenario is to define APH and how to differentiate between placenta previa and abruptio placenta. So let's start. Antepartum hemorrhage. It is bleeding from the genital tract after 24 weeks of gestation till the first stage of labor is called APH. Now for antepartum hemorrhage, we are having different causes which are both the placental and local causes. The placental causes are placental abruption, placenta previa and Vasa Previa. The local causes are maternal causes, which are cervicitis, cervical ectropion, cervical carcinoma, vaginal tears, and vaginal infections. Okay, APH is very important topic. There are a lot of scenarios that are repeated in the past papers, and there are the same questions that there is G8 P7 36 weeks pregnant and bleeding PV. Here is that compare the hemorrhage from placenta previa with that from abruptio placenta. And here is that G3 P2 35 weeks pregnant with severe abdominal pain, bleeding PV, shock condition and fetal distress. So what is the diagnosis, the differential diagnosis and the management? Here is a patient of G9P8 and FTP presented with BP 80/60 and severe abdominal pain. On examination, patient is pale and restless. And here, so all the symptoms are same. So we will discuss the antepartum hemorrhage as a whole. So we have discussed the causes that there are both local and placental causes. Now the incidence for APH are 3% and the differential diagnosis are placenta previa. Other causes of the APH: preterm labor, acute polyhydramnias, ruptured uterus, red cell degeneration and pyelonephritis. All these are the causes of the placenta previa. The management options for APH are history taking, that is, ask the patient how much she is bleeding, what are the triggering factors, is there any trauma associated with pain, last cervical smear done, and is baby moving or not. Then the examination, which is pulse, BP and temperature, is uterus soft, tender and firm, fetal heart auscultation or CTG, and speculum vaginal examination. The investigation options are baseline investigations, which depends upon the bleeding, that is CBC, clotting, and if previous suspected, then do gross matching of the blood. Ultrasound is done for fetal size, amniotic fluid, placenta position and presentation. Now placental abruption, the premature separation of a normally sited placenta from the uterine wall after the free period of viability is placental abruption, and we are having the types which are revealed and concealed. The revealed types of the placental abruption are 2 by 3rd of the cases, that is separation at the edge of the placenta and blood trickles down the cervix, and the concealed are present as uterine pain and end up with the fetal distress, fetal death, maternal shock and without bleeding. Okay, so these are the placental abruption types, which are both the concealed and the concealed placental abruption. Now what are the causes? These are fetal growth retardation and folic acid deficiency, abnormal placenta and multiple gestation, polyhydramnias and multiparity, hypertension, smoking, anticonvulsant therapy and cocaine use and fibroid uterus. Now the management options are, first of all, history is taken, that is the history of the vaginal bleeding, history of the abdominal pain, nature of the pain, pain is constant or frequent or short lasting, and any uterine contractions. Then GP is done, that is for pallor, maternal shock, and for abdominal examination, fundal height is greater than POG, and uterus is checked for abdominal palpation and typically reveals tender, tense, hard and uterus, woody hard, and then fundal height, which is fetal heart sounds which are not audible, and cardiotocography is done, which is non-assuring in the fetal, and ultrasound is demonstrated the placenta of the retroplacental clot. The risk factors are for placental abruption are maternal and fetal. The maternal are hypovolemic shock, clotting disorders, and widespread organs damage, and the fetal are hypoxia. The differential diagnoses are cholecystitis, gastritis, appendicitis, and Vasa Previa. These are the differential diagnoses of the placenta previa. Then the complications are feto-maternal hemorrhage, that is hypovolemic shock, and DIC, which is disseminated intravascular coagulation, and acute renal failure. The treatment options are ABC, that is stabilize the patients if in shock, then O2 inhalation is done, then pass IV line, take blood for the cross matching or coagulation studies, and then Foley's catheter to read the intake output, prevent hypotension, put patient in left lateral position, and then shock, quick delivery, and if it is the patient is in shock, then quick delivery is done. For dead fetus, once the mother is stable, vaginally deliver by artificial rupture of membrane. If the fetus is alive, then delivery imminent, that is induces labor and NVD. Fetal distress, then delivery via C-section. Before the delivery, always monitor, that is correct coagulation profile, and mother, that is weekly coagulation profile or ultrasound, and fetal monitoring, that is ultrasound scan for growth, and amniotic fluid volume, umbilical artery Doppler, and CTG. If premature delivery, then give intravenous steroids. In ultrasound, look for sacral agenesis, hydrocephalus, spina bifida, esophageal obstruction, and 34 weeks. Okay, give steroids if the baby is of 34 weeks. So we have discussed the topic. Let's revise that what is antepartum hemorrhage, what are the causes, the management, and then what is placental abruption. And after this, we will discuss the placenta previa. Okay. So, antepartum hemorrhage is the bleeding from genital tract after 24 weeks of gestation till first stage of labor. We have discussed the different causes which are placental and local. Then the incidence rate. Then we have discussed the differential diagnosis and the management options, which is history taking, examination, investigations. Now we are having certain causes which lead to IPH. These are, the first one is placental abruption. So we have discussed the definition for placental abruption, then the types of placental abruption, which are both the revealed and the concealed placental abruption. Then we have discussed the causes of the placental abruption and the management options, which are history taking and GP and abdominal examination. Then we have discussed the risk factors, which are the maternal risk factors and the fetal risk factors, and we have discussed the differential diagnosis and the complications and the treatment options. Now the coming towards the next cause of APH, that is placenta previa. So placenta previa is placenta that is implanted into the lower uterine segment of the uterus after the period of viability is placenta previa. Classification is that it is major placenta previa and minor placenta previa. In major, placenta is covering the cervical internal os. In minor, placenta is seated with the lower segment of the uterus but does not cover cervical os. The types are internal os, that is type 1, which is placental is in lower segment not reaching the internal os. Then type 2, which is the placental is in lower segment reaching the internal os. Then we have type 3, when it is partially covering the internal os. And we have the type 4 placenta previa, in which whole of the placenta lying in the lower segment covering the whole internal os. Now the risk factors are multiple gestations and previous history of the C-section and previous history of postpartum hemorrhage and dilatation and curettage and the uterine structure anomaly. These patients are at risk of the placenta previa. This is type 3, this is type 4, and these are the risk factors. That is multiple gestation, previous history of the C-section, previous history of postpartum hemorrhage and D&C, and uterine structure anomaly. Now, what is morbidly adherent placenta? There is a risk of placenta getting implanted into previous scar of C-section. We have placenta accreta, which is abnormally adherent to the uterine wall, then placenta increta, which is abnormally adherent into the uterine wall, and placenta percreta, which is abnormally adherent through the uterine wall. The clinical features are painless bleeding, recurrent in the third trimester, and bleeding occurs due to separation of the lower segment which develops in the third trimester. The differential diagnosis of the placenta previa are Vasa previa and marginal hemorrhage and placenta previa and the abruptions of placenta. Now the management options are that first of all GP is done, that is pulse is raised, PP is decreased and patient is pallor. Abdominal examination is done, fundal height corresponds to POG, fetal heart sounds are audible, uterus is soft and non-tender, and presenting part is free. The investigation options are baseline investigations, which are ultrasound will demonstrate the abnormal location of the placenta, and digital examination is contraindicated in placenta previa as this will precipitate bleeding. The treatment options are ABC is done, that is same as placental abruption. And for minor degrees, if relatively minor bleeding plus fetal is uncompromised, then for type 1 NVD is done, for type 2 NVD is done if it is anterior, and if type 2 is posterior, then C-section is done at the 37 weeks if no major bleed is present. And type 3 and 4 C-section is done irrespective of the general anesthesia, and admit the patient and keep under observation until 24 hours is passed without the further bleeding. In the major degree of placenta previa, there is recurrent bleeding, so admit before the 34 weeks, give steroids and tocolytics for lung maturity and delay of the delivery, and arrange 2 pints of blood, and C-section is the method of delivery. Okay, so we have discussed the placental abruption, then the placenta previa, which are the main causes of APH. Now coming towards the Vasa previa. Okay, now Vasa previa. So Vasa previa, it is the rupture of the fetal vessels into amniotic membrane near to cervical os and damage when membrane ruptures. The treatment is emergency C-section. Okay, so what is Vasa previa? It is the rupture of fetal vessels into the amniotic membrane near to the cervical os and damage when membrane ruptures. The difference between Vasa previa is and placental abruption is here. In placenta previa, the bleeding and pain. So the placenta previa is painless and recurrent bright red color blood is present, while in placental abruption, severe pain, revealed or concealed dark color is present. The symptoms for placenta previa are consistency of the uterus, which is soft and relaxed, and in placental abruption, it is hard and tender. In placenta previa, the pallor is less, while in placental abruption, it is increased. Hypotension is absent in placenta previa. In placental abruption, it is present. Fundal height is the same as that of POG in placental previa, and in placental abruption, it is greater than POG. In placenta previa, the palpations are soft, and on palpation, the soft and relaxed uterus is present, while in placental abruption, the tense and tender uterus is present. The fetal heart sounds are normal, while in the placental abruption, fetal heart sounds are absent. In preeclampsia, the preeclampsia and placental previa is nil, while in placental abruption it is present, and malpresentation is common, which is danger for the mother in placenta previa. Okay, so the malpresentation in placenta previa is common, while in placental abruption it is uncommon. There is no malpresentation in the placental abruption. So we have discussed the difference between placental abruption and placenta previa. Now coming towards the Vasa previa. So Vasa previa, it is a rupture of fetal vessels into amniotic membrane near to the cervical os and damage when membrane rupture occur, and the treatment is emergency C-section. Okay, the difference between the placenta previa and placental abruption is already discussed above, so that's why I have cut this portion. Okay. So up till now what we have discussed, let's go give a quick review to it. We have discussed the antepartum hemorrhage. Okay, then we are having different causes of the antepartum hemorrhage. That is APH. Okay, so this is the topic. Antepartum hemorrhage is the bleeding from genital tract after the 24 weeks of gestation till the first stage of labor. Then we are having different causes, which are placental abruption, and then placenta previa, and then we have Vasa previa. So we have revised the antepartum hemorrhage and the placental abruption. Now placenta previa, so it is the placenta that is implanted into the lower uterine segment of the uterus after the period of viability, and this is the classification, the major classification and the minor classification. So we are having four types: type 1, type 2, type 3 and type 4. These types are very important to memorize, so one should know this. Then we have discussed the risk factors and what is morbidly adherent placenta, then the management options and the abdominal examinations, investigations, the treatment, and the treatment for minor degree and major degree. Then we have discussed the Vasa Previa, that it is the rupture of the fetal vessels into the amniotic membrane near to the cervical os and damage when membrane ruptures. Okay, then we have discussed the difference between Placenta Previa and Placental Abruption. So here we have end the topic, the APH, that is Antepartum Hemorrhage. In the next video, we will discuss the postpartum hemorrhage, which is also a very important topic in the field of gynecology. And then we will discuss the multiple pregnancy or multiple gestation along with the scenario. Thanks for watching, and don't forget to like this video and subscribe my channel for further videos and the revision of the obstetric subject and many more subjects.